Are you very frustrated with your varicose veins? Watch this video. We're going to give you some answers. I'm Dr. Paul Zalza.
I'm Dr. Brad Wing. Welcome to Talking with Docs. We brought back Dr. John Chuback. Welcome, John. So nice to see you.
Dr. Chuback is back.
He is back, and he's an expert actually in varicose veins. This is where you like to spend most of your time during the week when you're working. And we're going to talk all about more the invasive side of stuff, so a little less on the compression stockings and supplements, but I think that's worth talking first.
Yeah.
And then we're going to work into maybe the injections and some of the surgical procedures to try to make these go away once and for all, because these are stubborn, they're debilitating, and they're very, very common.
Yeah, there's no question about it. Varicose veins in the United States, the estimate is that chronic venous insufficiency, which is sort of the full spectrum of venous disease of the lower extremities for people who have varicose veins, and even some who don't have visible varicose veins, it's about 40 to 50 million Americans suffering from that problem. And there are actually more days lost from work from venous disease every year than there are from peripheral arterial disease, if you can imagine
interesting
that.
Stat.
Yeah, so
I think that's the whole population of Canada.
It is, yeah, 40.
Exactly.
You've got a Canada's worth of venous insufficiency in the USA.
Yeah, it's a big problem.
Yeah.
All
Okay,
right,
so let's,
what is it?
yeah.
What is a varicose vein?
So it begins with venous insufficiency. So the veins are meant to bring blood back up to your heart. So that's kind of a neat trick. I mean, if you think about it, how does that happen? If we're sitting upright at this table, how does blood get from my ankles back up to my heart? And at this moment, the answer is through breathing. As we expand the chest, you create sort of a negative pressure vacuum. We call it a bellows effect, a vacuum, and that literally sucks blood up into the right atrium of the heart. When we're mobile, it's a lot easier because you have your calf muscle pump, we call it, which acts like two little peripheral hearts actually pumping blood back up to the heart. There are one-way check valves in the veins that keep the blood going only in one direction. And as a result of inflammation, long-term standing, a hereditary predisposition, those veins, the little valves in the veins, these little one-way check valves that are very, very delicate, like butterfly wings, they get inflamed, they get gobbled up, they no longer function. And then when you're standing or sitting upright, blood is pulled down by gravity into the feet and ankles. And that causes swelling, that causes pressure, that causes pain, it causes night cramps, all kinds of symptoms. And it can cause big bulging veins on the surface, which we call varicose veins, as that pressure fills up the superficial veins.
Okay, so a couple things. So first, we're mostly talking about the legs. Like we have veins in our arms, obviously throughout our body, but we're mostly talking about the legs.
Almost exclusively.
And then secondly, so we have a superficial venous system and a deep venous system. And these veins are essentially the same structure, just that the deep ones are surrounded by muscles. Is that fair to say?
Exactly.
Okay. And then we're talking mostly about the superficial ones.
Mostly. You can get venous insufficiency in the deep system as well. It's less common,
right,
and it's more likely to happen after somebody's had a blood clot, what we call post-thrombotic syndrome. That's a whole different discussion. But generally what we're talking about is venous insufficiency, meaning those valves are not working, those one-way check valves are not working properly. They start swinging back and forth like saloon doors, I always say, or they just get gobbled up completely. And so you get a lot of pressure in the lower part of the leg and big dilated veins.
Okay, so if some of those 50 million people in the USA and however many everywhere else in the world have this, let's talk about what they could do about it, and let's start from the least invasive stuff to the more invasive stuff. So little least invasive stuff, things people can try at home on their own to deal with this.
Yeah.
What are some of those?
Some of the things: weight loss, exercise, try to keep an active lifestyle, elevation of the legs when possible, lying flat on the back with the ankles about 6 to 8 inches above the level of the heart.
Right.
Compression stockings, what we call graduated compression stockings. Typically we suggest 20 to 30 millimeters graduated compression, meaning 30 millimeters pressure at the ankle and 20 millimeters at the calf or at the high thigh. So you're creating a gradient that helps the blood flow out of the leg back to the heart. Anti-inflammatory, antioxidant supplements like micronized purified flavonoid fraction, diosmin, hesperidin, all of those excellent flavonoids that we know about.
And these are typically from citrus fruits, right? Just so people know what they are.
Yep,
They might not know.
they're sourced naturally from citrus rind. They've been used for decades in Europe and now coming more and more to North America.
Well, you've helped develop that in North America, haven't you?
Yes, we definitely have. We, created
What's the name of your company again?
VitaSupport MD.
There you go. Okay,
We
good.
create
We'll put a link in it.
Yep.
Thank you very much. We create flavonoids for the circulatory system, and they're antioxidant and really help to support venous wellness and lymphatic health. So those are the conservative things that
Weight
can
loss?
be done.
You said that. You mentioned weight
Okay.
loss, yeah.
The first thing that I said. But that being said, we're often super critical of ourselves. So I have so many patients who come in who are overweight or obese, and they want to beat themselves up for their venous insufficiency and varicose veins. And certainly we advise weight loss and exercise and all of those things, anti-inflammatory diet, etc. But I have plenty of patients who are in tip-top condition, who are thin and slim and have rip-roaring venous disease and varicose veins because it's largely a genetic disorder that's passed in families.
Of the treatments you said, I mean, our longtime viewers will say, we've never heard talking with docs say, sit back and elevate your legs. They're going to be taking note. They're going to be like, I can do that.
That's
I
right.
can do that one. Forget about the exercise, the weight loss, and the compression stockings. I'm going to put my legs up and watch another episode of Stranger Things.
Bonanza.
But nice, saloon doors. So when it comes to those non-operative treatments, is this just to control the symptoms though? Like if you say you were compression stocks for like 5 years, your varicose veins aren't going to necessarily go away, are they?
No, they definitely won't
Like
go
it's
away.
essentially an irreversible problem, so it's to try to prevent them from getting worse and controlling the symptoms. Is that accurate?
Manage, not cure.
Yeah,
Okay.
it's incurable,
Right.
And it tends to be chronic and progressive. Now, different people will progress at different rates and to different extents. One of the interesting things that came out only a few years ago, a colleague of mine up at Harvard in Boston, or down at Harvard in Boston, from where we're speaking today.
Everything's down.
Everything's down.
Yeah.
It's downhill from
You're
here.
safe if you just go with the down.
Well, he discovered that, we've all seen a lot of venous insufficiency over the years, and when you see venous leg ulcers, which is the 6th stage, the highest stage, what we call clinical stage 6, venous leg ulcer, which is an open wound generally around the ankle area, inside or outside of the ankle, that's a terrible problem to have.
Yeah.
It can be very difficult to cure, very difficult to heal. It can even be life-threatening. People can get sepsis, blood infection, et cetera. And before you guys are putting in joints and things, it's an absolute no-no to have that.
Right.
So what he found is there's a genetic predisposition to venous leg ulcer formation. That's why not everybody with long-standing venous disease, even who've had it 30, 40 years, not everybody develops a leg ulcer. So we're learning more and more about all of this every single day, literally.
Okay.
Go ask your mom and dad if they ever had a hole in their leg, because it might happen to you.
That's right.
Okay, so you've tried all the non-op stuff. You still have significant varicose veins that you either don't like the look of, or you don't like the feel of, or both. So they're referred to someone like you. You've given them that whatever time it is, 2 months, 3 months of trial of the non-operative or non-invasive stuff. What's the first step in the algorithm of more invasive things?
A lot of it is patient-driven.
Okay.
You're not going to absolutely need any of these procedures, with the exception of people who have had significant complications, I would say. Venous leg ulcer, a blood clot, phlebitis, cellulitis. You can have bleeding, that's a big one. If you've had any of those significant complications, then I think certainly I strongly advise patients to go ahead and have procedures. Right. If it's just symptomatic, night cramps, heaviness, et cetera, many patients might opt only for conservative treatment forever. They might not ever opt in for surgery, but it's certainly an option for them to do that. Every patient then has to be evaluated as an individual and as a unique case. And you need, again, to go to a specialist who really specializes in venous insufficiency and varicose vein disease, because a sort of run-of-the-mill general vascular surgeon is typically much more interested in arterial disease than venous disease, and oftentimes they don't have the training in the background to formulate a proper treatment plan.
Right.
But the treatment plan is typically done in stages over a period of time.
Okay.
And the venous insufficiency, I always tell patients, it starts from the top down and from the inside out. So the main culprit in venous insufficiency of the lower extremity is the great saphenous vein.
Right.
That's the most commonly involved vein. It runs from your groin all the way down to your ankle, or really from your ankle all the way up to your groin. And it's a long vein, the whole length of your leg, and that's the one that's most commonly affected. There are other case scenarios that we don't need to get into today, but that vein should be treated first. And then you go to the surface, varicose veins that you see on the surface, spider veins, reticular veins. The analogy I always give is, it's as if you went down to your basement and there were 6 inches of water in the basement because you had a broken pipe. The first thing you have to do is go shut off the water main. You can't just get out the mops and sponges and hope that you're going to clean it up as that water is pouring in. So the first thing you do is take care of the venous insufficiency in the saphenous vein, and then you can approach the varicose veins that are on the surface. So there are a number of ways to do that we can discuss.
Okay, well, let's start at the beginning. What's the first thing?
Historically, the first thing, as you gents all remember very well, was a very aggressive operation called high ligation and stripping. And we grew up doing that. That was done in the operating room. When I say grew up doing it, in our residencies and so forth, in the hospital under general anesthesia. And it was a very bloody procedure. It was a very aggressive, traumatic procedure.
A lot of morbidity.
A lot of morbidity. The vein was literally,
It's barbaric. It's a little barbaric.
Barbaric.
Yeah.
Basically torn out of the leg with something like a straightened out coat hanger, believe it or not. And there was a lot of bleeding, a lot of pain, a lot of bruising, hematomas. Patients would spend a week in the hospital many times after this. So
Then you'd come
fortunately
and say,
that's changed.
"You're welcome."
Exactly.
Yeah,
So
not
in many
appreciated.
ways, in those days, quite frankly, the treatment was worse than the disease. So many people really tended to live with it. And the number of venous strippings, saphenous vein strippings that were done back in those days really wasn't that much because the patients didn't want it, and quite frankly, the surgeons didn't really want to deal with it. But as things have progressed in technology, one of the huge advances is what we call endovenous treatments.
Okay.
The big one that started the whole ball rolling is what we call endovenous thermal ablation.
Right.
And that can be done either with a laser or a radiofrequency device. And basically both of those things just generate high intensity heat inside the vein and basically burn the lining of the vein, cauterize the lining of the vein and shut it down. That's what I tell the patients, like heat shrinking the vein.
So you use an ultrasound to identify the vessel, and then you thread up essentially a catheter up the vein, and then do you start at the top and then slowly burn and then move it and then burn? Is that how it works?
Exactly right.
Okay.
So typically you would start around the knee area, maybe a few inches below the knee area, and we pass a little guide wire up the vein, and over that little guide wire, as you said, we pass a very narrow catheter, about the diameter of a cocktail straw, I would say, that goes up
the straw.
up the catheter, up the vein, and through that vein, you use that catheter as a little introducer device to pass a fiber optic fiber, which then basically, after numbing up the vein very carefully, that laser is used to basically sequentially, millimeter by millimeter, burn that vein and close it down. Of course, the patient doesn't feel anything because they have excellent, what we call tumescent or local anesthesia around the vein. And with a radiofrequency device, the areas that get closed are a bit larger at one time.
And so people are probably wondering, well, don't I need this vein for something? But the idea is that vein's not working properly. It's sitting there, it's not working properly, and it's contributing to the problem rather than helping. That's why stopping it from doing what it's doing is helpful.
Exactly, and I think that my experience as a cardiac surgeon comes in handy here because we often use the saphenous vein.
Take it right out of the leg.
Exactly, to do triple and quadruple bypasses, and no cardiac surgeon in his right mind would use a worn out varicose vein to reconstruct the heart. It'd be out of the question.
And I think that's what's unique about the venous system is that, like, if an artery gets blocked, the blood doesn't really have time acutely to go to other areas. That's why it has to be dealt with in an emergency basis. Whereas the vein system is all intimately connected. If you close up that one that's damaged, it's all connected so that the blood can be shunted around it without any significant consequence to you.
Yeah, exactly, and that happens immediately, and patients are often quite amazed that that can happen so quickly. But yeah, the blood is rerouted to innumerable normal veins that still exist in the leg. And so the blood flow out of the leg back up to the heart, the proper direction it should be going, improves dramatically immediately. And patients will often feel better right away, right after that, after a thermal ablation.
It's like Apple Maps. Got a traffic jam here. Instantly it tells me where to go around it.
Exactly
You
right.
will save 7 minutes. You
So-
will save 8 minutes.
So how long does this take? And then I guess post-op, like would they go home the same day? And then is there special precautions, or do they have to wear stockings or whatever? Like what's the post-op recovery look like for them?
Yeah, I liken it more to sort of a dental
Okay.
visit. You know, you walk into the office, you're wide awake. At the dentist, you sit in a chair. Here, you would lie on a procedure table, but you would be awake. Some physicians might give a little sedation or something. I haven't done that ever. I just use the local anesthetic, and we listen to a little music. We chit chat, you know, with the patient to keep things light and
Who
relaxed.
picks the music? Patient or you?
I do.
Okay.
Which is what kind of music? Just out of keep. Someone's going to ask.
Yeah, someone definitely will.
Generally, something a little bit, not hard rock. We used to listen to hard rock with the patient asleep when we were
They
doing
don't be
open
playing
heart.
AC/DC
Yeah,
one.
we used to do a lot of Led Zeppelin and things, but here would be more a little bit more 80s mix, you know, from my generation.
Fair.
Something
Fair.
not too elevator, you know, and not
Got it.
classical.
Got it.
Got it.
Yeah.
Okay, sorry. So then you've
important.
got the
It's important to
patient in the
know.
room, the music's going, you're talking, you're having a good time, cracking a few jokes, and then bang, you put this endovascular catheter in there.
Yeah, we try to be very, very gentle and kind of sneak the procedure by the patient. So,
Okay.
you know, sometimes at the end they say, are you ready, you know, did you just numb me up? I say, no, we're all done,
Wow,
you know,
that's amazing.
that kind of thing. So it's that sort of procedure that, you know, in the right hands of somebody who's highly experienced can be a very, very non-traumatic, non-anxiety provoking situation. You will be sore afterward, after a thermal ablation,
Fair.
and you can have some bruising, but typically managed just with NSAIDs like ibuprofen is, you know, my go-to, generally speaking, unless there's some contraindication. But nobody requires any kind of narcotic pain
Yep.
management afterwards, so it's really well tolerated.
That sounds better than the dentist to me.
For sure. Stockings afterwards, and do you do both legs at the same time?
Stockings afterward, yes. Graduated compression stockings, usually for a week after each of these procedures. I guess both legs could be done at the same time if you were in a situation where you had to do that. Sometimes colleagues of mine, when they go on mission trips and things like that, when they're
nice.
really pushed for time,
Yep.
they'll do that. But generally, we like to treat one leg at a time because, especially, you know, this is in the thigh area. You don't want to have two sore thighs kind of rubbing against each
Yeah.
other. It's hard for ambulation. And the big thing that we learned, as opposed to the old days when we were doing the strippings, there used to be bed rest afterward.
Right.
And that bed rest led to a lot of DVTs. It's a blood clot in the deep system of veins and pulmonary embolism, where blood clot can travel to the heart and lungs.
Get moving.
So now we know that the last thing you want to do is general anesthesia. You want to keep the patient awake, so they're talking and breathing and
Yeah.
on their own, and the blood is flowing. And immediately after the procedure, they get in their compression stocking, and they get up,
walking.
and they walk out to their car and drive home and go about their normal activities.
After having that relaxing music and conversation.
Yeah.
Okay, so you've dealt with this big vein, the main culprit, that the water valve that you shut off before you clean the basement. Now you got to mop up the basement. What do you do with these varicose veins now after you've dealt with this main one? Or do they go away now?
Well, that's a great question. Sometimes they do go away. Sometimes if that really is the main feeder, you'll see a dramatic collapse in the varicose veins that are being fed by it. And that's one of the reasons that we do it in a staged procedure, so that we can see how the patient's body has responded. If they don't need any more surgery, great, don't give them any more surgery. Before we go on to the management of the varicose veins in the superficial system, there are a few other options for the saphenous vein that have evolved over the years as well. Basically, when I first got into this procedure and this field of specialty about 20 years ago, endovenous thermal ablation was really the only option for closing the saphenous vein. But now there are a couple of other options. One is what we call ultrasound-guided foam sclerotherapy, where you can use a sclerosant agent, which is a medication Typically, it's a detergent, a soap-like medication that you can actually make suds out of. If you agitate it, you make bubbles. They call it foam. I like to call it soap suds or bubbles because patients often think of foam as part of a mattress or something that's physical that's going to stay in the body, but it's not. These bubbles, they're like scrubbing bubbles. I always say we're going to clean up your vein. But really what those bubbles do, that soap solution does, is it creates a chemical burn, a medicinal burn to the lining of the vein, the intima, just like you can burn it with heat, you can burn it with medication, and that closes. Remember when you're a kid, you get soap in your eyes, you know, and it would burn your eyes. So soap and detergents are caustic, you know. They can be, especially in a high concentration. So we use those soap bubbles in certain patients very effectively to close the vein. Typically, an indication would be a patient who had a smaller vein.
Okay.
The heat is more effective in getting the vein closed and keeping the vein closed in larger veins, and but it requires the anesthesia, the local anesthesia around the vein, which adds a little time to the procedure, adds a little bit of discomfort to the procedure, and after a thermal ablation, you'll have more post-operative pain and potentially bruising as compared to ultrasound-guided sclerotherapy with the foam detergent. The two common ones are sotradecol and polidocanol. These are the two medications that we use. They're about equally effective. The other sort of newer process, which I'm not personally a huge fan of, I'm not here to hate on anybody, but I'm not a huge fan, is basically a super glue. A medicinal super glue that is being injected into the vein to seal the vein shut. I don't personally do the procedure, although many people are doing it very successfully. So like I said, I'm not here to disparage it. I'm just here to raise awareness. What I personally don't like about it is that it leaves a foreign body behind in the body. That glue is never actually absorbed. And on, I would say, you know, rare occasions, but it's certainly not unheard of, people can have a reaction to that foreign body. So it has led to some complications, and all of these things have potential complications, so I'm not singling this out. But this is a different complication, which is people can get a hypersensitivity reaction, what's called a type 4 hypersensitivity reaction, and the vein actually has to be surgically excised. So the patient can wind up with a long incision on the thigh for a qualified surgeon to go in and cut that whole vein out to get that material out of the body. So, but
that's fair.
But it is very effective, and some people do like the procedure and are doing it routinely.
And so is foam really just a sclerosing agent that's got some air bubbles in it? So that it's kind of the same category, or is a sclerosing agent something that's different?
They're exactly the same. It depends on the concentration. It's a very interesting little story. I think people love stories. There was a gentleman named Dr. Tessari in France. And Dr. Tessari was a phlebologist. In Europe, they use the term phlebologist, a vein specialist, not a phlebotomist, which is somebody who draws blood, but a phlebologist is somebody who's an expert in vein disease. And they were using detergent already in low concentrations to treat spider veins and smaller veins, and very effectively. But when they tried using it in larger diameter veins, because the blood flow was greater in those veins and the veins were bigger, that soap solution just flushed through the vein and didn't close it. So the story goes, how true it is, I don't know, but I think it is a true story. Dr. Tessari one night after dinner did the dishes, and in the kitchen sink he noted all these suds that were taking a very long time to go down the drain, and he said to himself, I wonder if I went to the office and I could make suds out of the detergent and it had more contact time with the vein, would it be more effective in closing it? So he went and he very simply, he agitated that solution between two syringes and made suds and injected into a bigger vein and found that it was highly effective. So sometimes these things.
Hey kids, don't dismiss doing the dishes. You might stumble upon something.
Figure out something, taking out the garbage.
Do the dishes.
Cleaning your room.
That's right. Mowing the lawn. That's right.
Thank God he didn't own a dishwasher, or we never would have learned about this.
That's right.
Okay. All right. So are we done with the big vein yet now? We've got the endovascular techniques, we got the soap suds, we got the sclerosing agents.
I'll mention one more.
All right.
There are still indications for certain veins in the hands of a really well-qualified person. I'm biased. I like patients to see surgeons because we have lots of options and tools in our toolbox. There are other physicians taking care of veins. Many of them are very good, but they are a little bit limited in terms of their surgical options.
Sure.
Sometimes there'll be a superficial. The saphenous vein will come up in a very superficial way just under the skin, and I feel like burning it's not an option with heat because you can burn the skin.
Right.
And sometimes also in those cases, if you inject it, you'll get what we call phlebitis, inflammation of the vein. And that can be right under the skin. It can cause discoloration, it can cause inflammation, pain, redness, and that can take literally months sometimes to resolve. So in those cases, sometimes I will do a mini saphenectomy under local anesthesia, just a smaller superficial segment. You can easily remove through a couple of tiny incisions if you're qualified, and you get rid of that vein once and for all with very, very little postoperative discomfort.
This is the ambulatory phlebectomy.
It would be more of an ambulatory saphenectomy, but it's the same idea, removing a vein under local anesthesia.
Got it.
Okay. All right.
Paul really wants to go
Now
to
we're
the
good.
Yeah,
superficial
okay,
veins.
good.
He's so
All right,
desperate
so
to
we're
get
done
there.
with the saphenous
Yeah.
vein we've treated it.
Yeah.
We've treated it to death here.
Baby's gone.
We stripped it, we've endovascularly burned it, we've soaped it, we've excised a little piece of it,
And we did an amazing job.
and we injected
Patient's
it with
doing great.
sclerosing agents. One of all those things took care of it.
Yeah.
We said that the little veins now may go away, or the superficial ones may not.
Right.
And if they don't, what do we do?
Yeah. Again, we have to evaluate every patient,
Patient factors are important.
case by case basis.
Every case is different.
Some of these varicose veins can be about 3 millimeters in size, pretty small, but
Yeah.
bulging and seen on the surface. Those are typically injected with some concentration of that same sclerosing medication, the detergent, either sotradecol or polydocanol. It can be done as a liquid solution in smaller veins like that. Sometimes it needs to be treated with a little bit of foam again. That is the judgment of the physician, and that should be adequate. But sometimes these veins can be as big around or even bigger than my thumb.
Okay.
I'm not a proponent of injecting those veins.
Too big.
I think it's just too big.
Yeah.
Now, they can be closed, and there are many physicians out there doing that. They're doing foam sclerotherapy for large varicose veins. And there are some colleagues of mine that I've heard speak at meetings who are huge proponents that that's the best way to do things, but quite frankly, generally it's because they don't have any other tools in their toolbox. They're not a surgeon, and they don't feel comfortable to safely remove those veins in the office under local
What's your
anesthesia.
beef with injecting these big veins?
I think you get a tremendous amount of phlebitis afterward.
Okay.
It will close the vein, and the veins generally will ultimately be absorbed by the body, but you're going to walk around with a rip-roaring phlebitis for weeks or months, and it can cause long-term what we call hemosiderin deposition,
In the
or
skin.
yes, a hyperpigmented staining of the skin, which can be very, very distressing, especially, not that men aren't concerned
Sure.
about their appearance, but especially for women. I mean,
And that's the iron from the red blood cells.
the iron from the red blood cells that's now sitting in that vein leaches into the skin, and it
Yeah.
causes almost I would call it a semi-permanent biological tattoo.
Wow.
So it can take sometimes a couple of years for that staining to disappear. So I think in those patients, if you feel comfortable, which of course somebody like myself
hands.
does, a vascular surgeon, cardiovascular surgeon, a general surgeon, to numb up that area with a little bit of local anesthesia, make tiny, now we can make really micro, 2 to 3 millimeter incisions with, sometimes even with the tip of a needle, not even with a scalpel blade. And then we have a little instrument, a little hook that can just remove those segments of the vein, and the patients have an immediate medical result, decreased symptoms, cosmetic result. Essentially, they heal with no scarring.
Sorry,
and
so
it's
how
amazing.
are you removing the vein? So you make a little hole,
Put in a hook?
and then put a hook.
Right.
But then are you pulling it out of?
Yeah, it's what we call an avulsion technique, believe it or not. Generally speaking, you don't even need to tie the vein because we use that specialized anesthesia technique, which is called tumescent anesthetic. It's not just plain old local where you just put enough to kind of numb up the skin so the patient's numb, you're putting so much of that, you have to know exactly how much to do, of course, but so much of that very dilute anesthetic material around the vein that the vein goes into a very, very tight spasm.
With the adrenaline or epinephrine that you have in there.
You can use epinephrine. I don't even use it anymore. I think the
mechanical
mechanical pressure
Yeah.
causes, and veins, our vascular system is very highly reactive. So if you injure something, if you're poking around near a vein, it wants to protect itself by going into spasm.
Like a turtle.
Yeah, like in the old days when we were being chased by lions in the jungle and they would claw you, your body would create what we call vasospasm.
Right.
The vessels immediately go into contraction so that you don't bleed to death. Right. So when the body sees that, someone like me is there poking around needles and giving medication.
You're the lion.
I'm the lion, and it's protecting itself, going into a very tight spasm. So you get almost no bleeding, which is really interesting because it would have been great if we had known that in the days that we were doing the strippings under general anesthesia, because the patient was asleep, they didn't feel any pain, so you figured, well, I don't need any local anesthesia here, I'll just tear it out, which is why they had so much bleeding. The old stripping would have been much less morbid had we used the local anesthesia along with it, so the vein goes into spasm, so you get less bleeding. So anyhow, we numb up that vein with the tumescent, we put that vein into spasm, and then you can literally through tiny, and the amazing thing is long sections of vein can be pulled through a tiny little centrally located incision. Both ends just kind of pull right out of the hole. It's amazing.
Like a worm on a hook.
Exactly, like pulling an earthworm out of a 3 millimeter or 2 millimeter incision. And we didn't, years ago we would have made large.
Yeah.
I see patients who come back from, that they had their veins done, let's say 30 years ago, all kinds of staple marks and huge cross marking from, everything is getting better.
Did you have your knee replaced or something?
Exactly. Yeah, right.
Took out a vein.
We've learned a lot, and things have improved dramatically.
That's awesome.
All right. So that's
Microphlebectomy.
microphlebectomy.
Ambulatory microphlebectomy, which means the patient can walk in and out of the office and have, no need for blood work, no need for hospitalization, no need for sedation. They can drive themselves, and it's remarkable.
Still get the 80s music and the relaxing conversation?
Yeah, we chill.
Okay. All right.
Anything left, John? Anything that you feel like we didn't
covered
quite get to
everything on that
discuss,
vein.
or that's a good A to Z?
Yeah, and the final Z would be for the tiny little spider veins. Then we do sclerotherapy injection. That I think is the gold standard. Very dilute liquid solution there. Again, I like to use magnification because I'm a cardiac surgeon. I'm used to working under magnification, so you can really see all those tiny little fine veins. A very, very micro needle, very gentle injection that clears that up. And then the last thing I would say is reserved for tiny, tiny vessels that are not even injectable. Then there is some laser technology where we can use a handheld laser piece with a tiny spot size, 0.5 millimeter in size, and actually kind of zap those and paint those. That's typically considered more of a cosmetic procedure, but very effective. So we went from the biggest to the smallest.
Awesome.
Yep.
Dr. Chuback, the man with the brains about the veins, and if you want to just see him, the rose without the thorns, you can go to his social media. You don't have to listen to us yammer on. You can get it straight from the expert's mouth. Check that out. We'll put all those links in the description below.
And
we
now
really want to thank you for just sharing that wisdom and history about veins.
So if you like this video, please like it, subscribe to our channel, share it with someone that you think might benefit from this information.
And remember, you are in charge of your own health. Thank you again.
We'll see you next time.
Thank you.